Pastor Chooks, along with his wife, Pastor Toyin, are the lead pastors of Resurrection Life Church in Johannesburg, South Africa. Through them, God is raising an army of ordinary men and women who are transforming and uplifting the standard of life in their communities through understanding and applying biblical principles. Pastor Chooks and Pastor Toyin frequently host workshops, seminars, and conferences for transformation and uplifting of the complete man, complete woman, and wholesome families. Some of the events and programs include the Dream Achievers seminars and conferences, Kingdom Financiers conferences, marriage enrichment courses and seminars, for wives-only seminars, single ladies boot camps, limitless men's seminars. They are also the founders of the Power of Woman Academy, a group mentorship for high-impact women. They also host the annual Power of Woman conferences and events. For more information, please visit www.idelight.co.za and www.reslife.org.za or WhatsApp +27 814 210 835.
Welcome, welcome, welcome. It's a Thursday evening and it's the Amazing Power of Woman broadcast. Right here on Thursdays at 7 p.m. GMT +2. This is a good time for you to share this link with a friend. If you're on the broadcast right now, please share this link with a friend, or either on Facebook, share the Facebook link or the YouTube link, and just invite your friends. Tell them something powerful is happening online today and they can be part of it. So share it with your friend, with your mother, with your sister, with your work colleagues. Every woman out there needs to watch tonight's broadcast, and it's our once a month Ask Your Gynae session. Why do we have our Ask Your Gynae session? This broadcast, this whole broadcast is brought out because of this book, The Amazing Power of Woman, book written by Pastor Chooks Obina Ugohe, and I'm his wife. My name is Toyin Ugohe, and this book has been written by my husband, Pastor Chooks, The Amazing Power of Woman, where he details the power that God has given each one of us, every woman out there, and our aim is for you to understand what that power is so that you can live your life fulfilling all that God, or having all the capabilities that God has put inside of you to be able to fulfill and be all that God has called you to be. That's our assignment, to help you know what it is that God has given to you so that you can be the best that God has called you to be. Amen. And so we have our Ask Your Gynae session. This ministry, this broadcast is about us bringing revelation, knowledge around three aspects of a woman: her spirit, her soul, and her body. And so regarding her body, we want to bring information, vital information for us to know about our body. We realize, because of the programs that we do, both on our academy, the Power of Woman Academy, where we have sessions about us just knowing our body and being able to ask questions. There are things that we fret about, and are just things that are happening because of your cycle, your peculiarities, your history, and all of that. And it's important to know what you should fret about, what you shouldn't fret about, what will pass, what is just common because of the peculiarities around you. It may just be that you need to change your diet, or different things that we need to do that can help us and aid us in the cycles that we go through as a woman. So that's what the Ask Your Gynae is about, to bring you information, knowledge to help you. And of course, we also believe in the power of prayer, the power of God to heal, the power of God to intervene in our situations. And so beyond just the medical, we believe that there's a power of God to intervene in our situations and bring about healing even into our body. So we want to eliminate the things that are just normal, that you need to just deal with in simple ways, and the things that you just need to deal with medically. A woman will still need to go to the doctors to have her baby born, or to go through the process of pregnancy just to check the baby. So there are things that the medical doctors have been skilled by the wisdom of God to be able to help us as women. But beyond that, we have the power of God also to intervene in those situations that goes beyond science. And so today we have another session of the Ask Your Gynae. And so Pastor Chooks, along with Dr. Gugu Gamedze, will be taking that session just after our ad break. And all of those things that we have, this information that we have, we will also make them available on our Telegram channel. That link will be coming up on the screen just there, t.me/amazing power of woman. This is a public channel, a Telegram channel, where if you subscribe to, you can get information. The audios of this broadcast will be put there. But beyond that, the questions that some of us send through on our broadcast, we will have the answers available on the Telegram channel. We can't always answer all your questions on the broadcast, but what we can do is have those questions answered, and those questions the answers to those questions, we'll make them available on our channel. So if you are subscribing to our channel, you'll get information about different things, whether you're a single lady, you're married, you're engaged, or whatever stage you are in your life, whether you're even a widow, or whatever stage you are in your life you're going through, we have resources that we can make available to you. And so joining our channel is quite vital for any woman out there. There's a community of women just learning and understanding the things they need to learn to make them, to have enough tools to be able to journey through life in a way that pleases God, and where they can maximally be of benefit to themselves first and foremost, and to the community around them. That's our mission, that's our assignment. And so after this broadcast, after this the ad break, we will have Pastor Chicks Obina Ugohe and Dr. Gugu Gamedze on the Ask Your Gynae session. Have a beautiful one today. God bless you.
The Power of Woman Academy is a group mentoring program for high-impact women. Women who want to change their lives and their worlds and move on to the next level. Power of Woman Academy is aimed and tailored at unleashing the passion and greatness locked inside you as a woman as you walk the journey of life over the mentorship period with our team of distinguished and well-accomplished mentors from all walks of life. Our mentors are indeed destiny helpers. These mentors come to inspire you. They come to encourage you, to challenge you, to teach you, to stretch you, and to empower you. They are committed to helping you fulfill your highest potential and help you birth your wildest dreams that have been placed in you by God. For more information about the Power of Women Academy, please visit www.powacademy.co.za, or for inquiries, call 064 200 1545.
All right. Well, good evening, everybody. A big thank you to my dear wife for doing the openings for tonight. It's another Thursday evening, and we are on for another edition of our Ask Your Gynae session. As we all know, or if we don't know, the Amazing Power of Woman broadcast tries to reach women, spirit, soul, and body. And once a month, we are dealing with the body of the woman. And that's where we do our Ask Your Gynae, where we bring in our guest doctor to come shine some light on issues that pertain to the body of the woman. Tonight, we are blessed to have once again our delectable, beautiful Dr. Audrey Gugu Gamedze. Welcome, Doctor.
Good evening, Pastor. Good evening to our listeners and viewers. Thank you very much for the kind introduction. I'm happy to be back again onto our program, Amazing Power of Woman.
Right. Thank you for obliging us to be here again. Thank you for your ministry to women. You are a blessing to me. Just the fact that you bless women every day, you're a blessing to me. Thank you. Today we have a very powerful and very interesting topic. We are going to be dealing with miscarriages. We've asked Dr. Gamedze to come shine light on that subject. It's a topic that has brought a lot of pain to so many women around the world. And it's something that we need to deal with. Like you know, we will approach it from the medical side. We'll also eventually approach it from the spiritual side. But for today, we are dealing with the medical side. Dr. Gamedze, right?
Yes, we'll talk about what I know well.
All right. We are dealing with the medical side of miscarriages. And Dr. Gamedze is here to give us the science and tell us what medical science says and what what we need to know about miscarriages and, preventing it, moving on after it, and so on and so forth. So I'm going to hand over to Dr. Gamedze, and she's going to teach. I am not sure how much of what she has we're going to cover today. If we're not able to finish it today, we will carry it over to the next edition of our Ask Your Gynae session. All right, with Jesus' joy, I hand over to our dear sister, Dr. Audrey Gugu Gamedze. Over to you, Doctor.
Thank you very much, Pastor Chooks. And I must also reciprocate by saying I appreciate the ministry that you have for women. Most women do not have access to this kind of information, but every time we come to the house of the Lord and we can unpack what we know as children of God who are in the health fraternity, it makes really a huge difference. May God bless you for that. Okay, miscarriages. I've prayed about this to ask the Lord to assist me negotiate empathetically and also in a much informative manner that is not gonna leave women wounded, but that is gonna leave them at least much more informed and enlightened about what a miscarriage is. My sympathy goes to those who have gone through this painful event, and also my enlightenment goes to those who are yet to experience it. It is a very, very sensitive topic, but like we have said in the house of the Lord, there is everything. We need to assist each other, help each other go through this. And if the doctor is that much useless, Pastor Chooks will make sure that you negotiate through this curvy road of miscarriages with the help of the Holy Spirit. Okay, statistics says that almost 1 in 5 women in their lifetime will experience a miscarriage. It is very much amazing that in my practice as a gynae, I can say almost each and every patient that I've seen has gone through this at some point in time in their lifetime. So meaning that in our era now, miscarriages are much more common or are much more recognized than they were in the past. Part of this, we owe it to women being much more proactive in seeking medical attention and also wanting the diagnosis of pregnancy very early in their pregnancies. Some women would report as soon as they miss a period, and it's easier then to monitor that pregnancy. Yet in the past, they will wait to say, okay, I've missed a month. Let me see if I miss the next one. Maybe before you miss the next one, you've already started bleeding. But instead of interpreting that as a miscarriage, it's most likely for somebody to interpret it as, oh no, it's just a late period. So what is a miscarriage? If somebody says he's had a miscarriage, what is a miscarriage? In simple terms, it is a pregnancy loss. At what age? Any pregnancy loss before 5 months, which is 20 weeks, that is a miscarriage. After that, it can be considered as a preterm labor, preterm delivery, but I must say that the margins vary more according to when can that baby that came out from the miscarriage be taken for resuscitation and so on. So this varies from country to country, depending on how well resourced the country is. The UK uses 20 weeks because after that, they can try and take the baby for resuscitation. In South Africa, we take from around 26 weeks or when the baby is about 800 grams. So any pregnancy loss before then, it can be considered a miscarriage. So somebody can say that, I lost a pregnancy at 25 weeks. I could see the baby move when the baby came out. I could see the baby attempting to opening mouth to cry. That would still be considered a miscarriage because if the pediatricians would take that baby to try and resuscitate that baby, the outcome will not be positive. So that is why it's still classified under miscarriages in our South African setup because we are low resourced. Why are we talking about it? What's the significance of a miscarriage? Like we have said that it is a loss, We want to know, why did you have the loss? Secondly, it is a setback. The setback is in order of, you wanted to have so many babies, you wanted to have started your family at this time, you wanted to have finished by this time. So if you get a miscarriage, it is a setback. The emotional component of that loss is not, we cannot calculate it. Some women, they wouldn't want to fall pregnant after that. Others would want to fall pregnant, but emotionally they are not the same. Others get serious psychological disturbances which make them underperform at work, underperform at home, even go through divorces. It's a serious setback. So we need to discuss miscarriages. Also, it can be an indicator of an underlying problem or medical concern, or it can be a trigger of an underlying problem or an underlying concern. So if I say it can be a pointer, let me make an example of a lady who has an incompetent cervix, a mouth of the womb that just opens out of the blue and vomits out the baby. So if that woman had not fallen pregnant, had the miscarriage, it would have not been that easier to diagnose that there is a problem. When I say it can be a trigger for somebody who has an underlying severe emotional disease, if it had not been for the miscarriage, we wouldn't have diagnosed that there is a problem. Some other women have got clotting diseases which would have not been diagnosed if they had a pregnancy and they had a pregnancy loss. So it works both as a pointer and also as a trigger of an underlying problem that needs to be attended to. That, having said that, it is applicable for both the male side and also the female side. As a gynae, I am so fortunate that I rarely see the male side. So, but if there is a genetic problem, we can assist the family to seek medical care. Okay, what would cause a miscarriage? There is a variety of classes of causes of miscarriages. I've tried to group them crudely into some groups in no specific order, of course, but for the purposes of the discussion, and also to trigger some questions, which I hope we will have a chance to answer some days. It can be genetic. There are some people who carry some genetic diseases, which when they come to form a progeny, it is most likely to be deformed. Progeny is when the family tries to fall pregnant. It can result in a deformation. I always say that nature has a way of assessing that this will be incompatible and then allows for a miscarriage. In science, we used to call it natural selection. So if there is a genetic problem, a miscarriage will happen. Although some of these genetic abnormalities can be allowed to delivery, others can come to a state of malformation and miscarriage. Others will be malformed and get miscarried at a later stage in life. That can be dissected into detail if you are interested at some point in time. Secondly, it can be anatomical. Let's make an example of a lady who has got big fibroids. They are sitting in the womb, they are squashing the baby, they're squashing the pregnancy. That baby can be lost. Also, there are people who have got a duplication of the womb. How can I put this? Okay, when a human being is formed in the womb, you find that there is a left side and a right side. With the rotations that happen when God is busy making the human being, the left needs to come to the right and they meet in the midline. That is why when you look at yourself, you can see that there is an imaginary line that you can draw through your face to have the left and the right. Same thing with the womb, there's a left and the right that comes together when they come together, the dividing line needs to melt away. Some people, that dividing line does not melt away. It's called a septum. So if the womb has a septum, we can have a miscarriage because it doesn't allow stretching. Or if the womb has what we call a horn, that's like an underdeveloped womb, that can also result in a miscarriage because the womb does not get a chance to stretch as much as it would. And then there are also infections. There are infections that if a woman gets in the first trimester or early in pregnancy, that can result in a miscarriage. Let me make an example of syphilis. It can give you a miscarriage, or any disease that gives you a very high fever in the first trimester, you can get a miscarriage. We've seen miscarriages from malaria, from brucellosis. We've also had recently what they call the Poloni disease. We've seen people getting miscarriages. So infections play a huge role when it comes to miscarriages. And then we also have diseases like thrombosis, which is formation of clots in the blood vessels. Those are coagulopathies. But if I say it's just clotting, abnormal clotting diseases, it can be because your blood is too weak or too thin, or your blood forms clots. That can also block those micro blood vessels that go to the baby. And if those are blocked, baby is deprived of blood and oxygen, and the baby cannot grow, or the baby dies. Also, if that happens on the placenta will not be as productive in allowing the baby to grow. That can also result in a miscarriage. Let me just stop there when it comes to the causes of miscarriages. And then, how do I know as a woman that I'm having a miscarriage? That's usually a very fine line in the diagnosis of a miscarriage from the patient's perspective. For me, the important thing is to know that you are pregnant. If you know that you are pregnant, it's easier to see if there's something going wrong with the pregnancy. Let's make an example. There is Gugu. She is about 8 weeks pregnant. If Gugu doesn't know that she is pregnant, it will be difficult to know that she is having a miscarriage. But the greatest symptom of a miscarriage is vaginal bleeding and also pain. I will dive down into these symptoms. I'll just take a while talking about the bleeding and also the pains. Number one, the bleeding is usually outside your cycle. Let me make an example. If a woman misses a period today and then gets vaginal bleeding or spotting the next time she was supposed to be having a period, that may not be interpreted as bleeding, but it may be interpreted as an implantation bleed. Or if, most relevantly, if she's supposed to be having a period today and she does not get a period but only spotting, that can be interpreted as an implantation bleed. An implantation bleed is not a bleed that will fill pads, but you may use a panty liner and it will not be full, and usually it's not a painful bleed. Some women also go into just a spontaneous bleed with clots, regardless of the fact that they did not know that they were pregnant. Commonly, I see that with my patients who are on the injectables, which don't allow them to have their monthly period. So if an oopsie has happened whilst you are on the injectable, because you don't get your periods, it will be difficult to see if you are having a miscarriage. But when you get to the doctor does a pregnancy test. It is then that the doctor will tell you that you are actually miscarrying. Then pain. Pain is a common and an uncommon symptom of a miscarriage. Why is it a common symptom? If the pregnancy is, if the pregnancy has been diagnosed and also it's sitting very well and it's been going well, you are most likely to have pain when you are miscarrying. Usually the pain comes not at the time of expulsion. You will have the pain as an indicator that something is not going right. So if you ignore the pain symptom, you are most likely to lose the pregnancy. But if you're sensitive to the pain symptoms and you present to your healthcare worker, oftentimes that pregnancy can be rescued. So with most miscarriages, the pain will present before the bleed. The common narrative that I get is, I had some period pains the day before, and then this morning I woke up bleeding. So that shows that a miscarriage will always indicate, or an abnormality in the pregnancy will always say that something is about to happen. If you ignore that subtle sign, you might be presented with the bigger event of God. There is, however, one kind of pregnancy that is not painful. The patient may bleed just a little bit, and after that, the baby comes out. That happens with what we call an incompetent cervix. So that is the mouth of the womb that is so weak that with the weight of the pregnancy, instead of staying firm and closing in the pregnancy, it just relaxes every day. And then one day you'll be walking down the street, you feel like something is coming down, you feel like bearing down, and when you do, the baby comes out. And the classical scenario that kind of a woman will give is, I just felt like I need to push out of the blue. And when I pushed, either the water broke or the baby fell down inside the sac. That is another very, very painful scenario in the miscarriage, in the types of miscarriages that we have. So those are the two main symptoms. Then if the miscarriage is secondary to infection, one may say that I did see an abnormal discharge, I did get a temperature, or I had a flu before. Those who get miscarriages following flu-like symptoms, usually they blame it on their GPs. And I said, I went to the doctor and the doctor said I had flu, gave me medication, and after the medication, the baby came out. It's usually because of the fever that the miscarriage happens. What are the types of miscarriages that we know, and how does a mother or a woman differentiate what is most likely to be happening to her? The commonest kind of a miscarriage is a complete miscarriage. That is, you did fall pregnant, you did have a miscarriage. When you get to the doctor finds nothing in the womb, but the pregnancy test is still positive. So by the way, the pregnancy test will take anything between 14 to 21 days to be negative. So if you have a miscarriage today, you do your pregnancy test next week, it's most likely to still be positive, depending on the kind of a miscarriage. Then the second kind of a miscarriage is an incomplete miscarriage. The reason why it is called an incomplete miscarriage is because when you get to the doctor will tell you that I cannot see the baby, but I can see the remains. I normally put it to my patients that we don't see the citizen, but we can see the house where the citizen, or we can see the chair where the citizen was sitting. So that's what we call an incomplete miscarriage, meaning that the event happened, we lost the baby, we lost the pregnancy, but we can still see inside the womb that there was someone here. The other type of a miscarriage is what we call a missed missed miscarriage. By the way, let me just go back a little bit. Miscarriages are also called abortions. That's the medical term, the right medical term. But because we deal with humans, we deal with emotions, the term miscarriage sort of makes it sound a little bit more palatable, respectable. The word abortion, then it has been solely be transported for use for people who elect to lose that pregnancy. So when you get to your doctor and the doctor says, oh, you're having an incomplete abortion, it sounds very insensitive, but that's the right way for it to be pronounced. So every time I say miscarriage, it's interchangeable with abortion. Okay, so I was talking about missed miscarriages. In case of a missed miscarriage, now the woman is pregnant, confirmed or unconfirmed, the pregnancy has been doing well, and all of a sudden, there is an insult that now makes the baby stop growing and stop being alive. So it's a dead fetus or a dead embryo. So when the doctor does the examination, one of two things can be. Number one, when she does the ultrasound, may find that the baby has got no heartbeat. If you had seen the doctor before, maybe the doctor had measured the pregnancy to be around 9 weeks. When you get to her again this time, finds that the pregnancy is now about 7 weeks. So it means that at some point in time, the pregnancy stopped growing and there was shrinkage that happens. In that way, we call it a missed miscarriage. So you can still see the baby on scan, but there's no heartbeat and there's no movement. The other scenario of diagnosing a missed miscarriage, we can do the levels of the pregnancy hormone. So if the level of the pregnancy hormone today is about 16,000, when we do it in 48 hours time, it should be at about 32,000 or approaching 32,000. We say that the level of the pregnancy hormone doubles. So that's a sign that a pregnancy is growing. So if you get to the doctor and the doctor says, I'm not sure whether the pregnancy is growing, the pregnancy is alive, rather let's do the levels of the pregnancy hormone, and from that we can be able to tell whether the pregnancy is growing or not. So what we're trying to ascertain there is the doubling time. So if that is not happening, that is a confirmation that the pregnancy is not growing. So we've done a missed miscarriage, we've done an incomplete miscarriage, we've done a complete miscarriage. So when it comes to the treatment now, how do we manage a lady who has just lost a pregnancy? I'm sorry to keep on saying lady, lady, lady. It's supposed to be a family, but I want to keep that space a little bit wider so that you know that it's not a gynae that manages a miscarriage from a family perspective. A gynae will work with the patient and then send you elsewhere to be able to deal with the loss as a family. Okay, not that I'm being insensitive. So, treatment, first of all, starts off with confirming that yes, there is a pregnancy. Secondly, how far pregnant the lady was, and then what type of a miscarriage it is. So I'm going to try and tackle each of those miscarriages management-wise and see how far we go and what can overlap in the care. Number one, we want to diagnose a miscarriage before it happens. I know it sounds a little bit contradictory, but we want to know who is at risk of a miscarriage and then manage that before the miscarriage happens. Let me make an example. We know that you've got a clotting disease. What we are going to do is to put you on folic acid. We want to put you on medication that is going to thin your blood, and then we want to monitor you when you want to start falling pregnant. We don't want to see you when you are pregnant with a clotting problem. Then we manage that. That is a proactive management of a miscarriage. If we know that you've got an incompetent cervix, that is the mouth of your womb opens up sporadically to vomit out the baby before its time, we want to make sure that you have a stitch in place at the right time during your pregnancy. And also we want to make sure that you don't have a collagen disease. A collagen disease is a disease that makes the structure of your muscles, the structure of your cervix to be weak. If we know that you've got a collagen disease problem like SLE and all the other connective tissue diseases, those can be treated and managed before you start falling pregnant. Infections, if we know you are HIV positive, for an example, we need to make sure that the viral load is under control before you start falling pregnant. So it is very much important that if you do want to fall pregnant, you see your health practitioner for an initial or a preconception assessment. Preconception assessment is not commonly preached. No, I'm not in church. It's not commonly encouraged in our communities, yet it's very important. If you've got epilepsy, for an example, there's certain medication that you cannot use if you want to fall pregnant, because we know that if you use that kind of a medication, you are most likely to have a baby that is abnormal, or you are likely to have a baby that will stop growing at some point in time. So all those things need to be factored for in management of miscarriages. And then women with a history of miscarriages, those need to be assessed as well outside pregnancy to ascertain what was the cause of the miscarriages, at what point in your pregnancy did you lose the baby, because if it is a first trimester miscarriage, we know what's the most likely cause. If it is a second trimester miscarriage, we know what's the most likely cause. So we can investigate along those lines and have solid treatment instituted before you fall pregnant. So in case of a complete miscarriage, there's nothing more that can be done at that particular time, except for now investigating the woman as to what was the most likely cause. If there is a cause that can be identified, then that can be managed in that window or for the next pregnancy. In a case of an incomplete miscarriage, that can complicate if it has not been attended to very well. Number one, the greatest complication is hemorrhage. That woman tends to lose a lot of blood. If unattended to, you can bleed to death, you can bleed to coma, you can bleed to transfusion. So it is very important to attend to that kind of a miscarriage. Secondly, if it is not attended to, you can get what we call an infection. If the infection sets in because now you've got all that pregnancy tissue being good food for germs, then you can proceed into septic shock and die because of the infection. So you need to be attended to. The greatest thing that we do then, we do what is called an evacuation. In the streets, they call it a DNC. So we clean out whatever is left over from that pregnancy and then cover the patient with antibiotics and then continue to monitor as to from that leftover tissue. We send it for tests. Can we find out what was the cause of the miscarriage? And then if it is a missed miscarriage, for that patient, we can, this is the kind of patient that's, for me, it's always difficult to manage. The main thing is because you find that the patient is having a very much wanted pregnancy. So along those lines, you need to give them time to accept that, yes, this pregnancy has been lost. And also the second important thing around a missed miscarriage is that you need all that genetic information to take for analysis as to whether can we find out what was the cause of the pregnancy. And then when the patient has emotionally settled and ready for the evacuation, then you clean out the womb, take out all that information from the pregnancy and send it for test. Usually, we do get what was the cause of the miscarriage. And then for women who've got an incompetent cervix, we put a stitch for them. Can I just wind up so that we can have lots and lots of questions coming up after this? Can I wind up by saying that miscarriages are still common during our time? And secondly, miscarriages are manageable. Management for me starts from knowing what is the cause so that we can prevent it from further happening. And lastly, miscarriages are still a multidisciplinary point of care event. It cannot be only your gynae managing it. You need the psychologist, you need the geneticist, you also need your pastor, because there are some things which I'm sure Pastor Chooks can enlighten around that. Demonic activities which can also come from our bloodline, predisposing us to miscarriages. So let us be well informed about them so that we can prevent them and also so that we can help others. Thank you very much, Pastor Chooks.
All right. Thank you, Dr. Gametse. Thank you so much. It's been quite a lot of medical information for me to put together in my head. But thank you for sharing. I know the pain of miscarriage. I know the trauma that it causes for a lot of women, especially when you come from a culture where your womanhood is not validated until there's a baby. And there are, in fact, that's what it is in Africa. You know, you are coming into a family as a married woman. You are not established until you drop a child. Now you are here having miscarriage after miscarriage, and then there are mockers. Mockers are mocking you. It can be a lot of pain, especially when you have, been waiting for a while. I know I'm aware of a number of cases, you've been believing God 5 years, 7 years after marriage, and then you fall pregnant. And now we are celebrating that you've fallen pregnant. And then 9 weeks down the road, you lose the baby. And it returns you back to where you don't want to be. So I know the pain of it, and we are very sensitive to that fact. We would like to pray for anybody who is going through such a situation. Our number will be on the screen shortly. You need to, it's already there, okay. You need to send us a message, a WhatsApp message, so that we can deal with your matter, discreetly. We don't want to, we know how sensitive it is. So if you need prayers and you need counseling or you need any kind of support, myself, my wife, Dr. Gametse, we are available to help you after the broadcast, after the show. So send us a message. We will call you. We will schedule a time, and we can, attend to whatever it is. But I do know that, there's a woman I know who had 12 miscarriages. 12. Miscarriage after miscarriage. That's a lot of iterations to go through. How do you manage your psyche going through that number of losses? Because each miscarriage is a loss. So please reach out. Don't die in silence. Don't carry that burden and allow the enemy to sit on you and start blaming you on things. I once counseled a lady, and when she was a single woman, she had a lot of indiscretions, and she aborted babies. She fell pregnant maybe 3 or 4 times and she took them out. Now she's married. It's a problem. Every time she falls pregnant in her husband's house, she loses the baby. And the devil keeps on telling her, it's because of what you did. You know, the babies that you took out, they are fighting you. And she will have these dreams where she sees those babies fighting her when she gets pregnant. And then when they've had to fight her, when she wakes up, the pregnancy will be lost. So there are all those kind of things that are going on in people's lives. It's not the will of God. If you had made mistakes and you've repented of it, my Bible tells me that God forgave you, and we need to deal with that door that opened, that Satan is now using to hold you in guilt, in condemnation, and in shame. Because as long as you carry guilt, condemnation, and shame, you create an environment for Satan to keep attacking your pregnancies. So you want to reach out to get some help. All right. We will take a few questions. Dr. Gameze, we're running so short on time. So we'll take a few questions and we'll continue this conversation in our next session. Maybe our next session we will actually devote it to more of questions, because I know a lot of ladies who are watching right now, you've got lots of questions. So please type your questions on the live stream and send it. If you don't want to, send it that way, you can use the number on the screen and send it as a WhatsApp message. If you want to be more discreet about your questions and you don't want it to be on the live stream, send it as a WhatsApp message, and then we will attend to it. If it's something that we can address publicly, we address it publicly, anonymously. If it's something that we need to address with you privately, we will do so. But whatever you are going through, my dear sister, I just want you to know that Jesus sees your tears. Jesus sees your tears, and he cares about you, and he wants to help you. So we are here as vessels in the hands of God that God can use to pour healing, restoration, and actually stop the thief from stealing from you. A lot of the babies that you are losing is the thief who came, the one that Bible says he came to steal, to kill, and to destroy. He's the one stealing from you, and we need to stop him. All right, he's not that powerful. We need to stop him. Okay. Dr. Gameze, I want to throw a few questions to you. There's something you said that is a bit concerning for me. You say we are low resourced in South Africa, and people in the UK are not low resourced. What is it? How long is Africa going to continue to bear this shame? What is it? Why are we low resourced? What is it? That our doctors are not qualified? What is the story? Our hospitals are not competent? What is it?
Being born in Swaziland, I've never mastered how to talk to South Africans, but I always try.
Okay.
It's a political posture.
Sure. Politics in health.
Because if you are in private, we will take the smallest baby that is showing resilience to be ventilated. And then that baby will decide for us if how much do we need to do. Like we've had babies born 600 grams and they fight and they get discharged 2-point-something kilograms, and even their neurological outcome, it becomes within what is acceptable. So for doctors to take a baby to make a decision whether to resuscitate or not, it's based on availability of equipment and also the neurological outcome. So if I take a baby that is 20 weeks by pregnancy dates, that baby clinically, or according to what we learned from school, is less likely to be mentally functional because the brain was not at its utmost development, and also the lungs were not at their utmost development to be receptive to being given oxygen and facilitate the exchange. So we know that even if we can take that baby, put on the machine to do everything for it, the outcome will still not be what will be a fully functional human being. Having said that, I am not God. We always on the report of the Lord. And also, I am not a pediatrician. So what I am talking about now is based on my interaction with pediatricians and what I see as a doctor who interacts with pediatricians. And then secondly, if I have got two machines, or let me say I've got two babies who need to go onto the machine. The one baby is a 2.5 kilograms baby that was born and is all of a sudden struggling to breathe. The other one is a 23 weeks fetus that was born as a miscarriage. I need to make a decision to say, I've got only one machine. If I put the baby that is 2.5 kilograms on the machine for the ventilation and all the other support that the baby may need, that will take me at most 7 days. Then I have the machine ready to be used by another patient. If I take the 23-weeker, who maybe is going to be 550 grams, take that baby into the machine, that baby is going to spend at least 6 months on the machine, and also I am not sure of what outcome am I sending to society. So those are the decisions that I get faced with now as a health practitioner. So that is how we then, looking at the kind of patients we get and the kind of outcomes we get, then we get to say, if we get a baby who is less than this weight, this baby we are not going to put on the machine, we are not going to resuscitate to the Z of resuscitation, because we know the baby is going to take very long on the machine, obstructing other patients who would have benefited from the machine and used it for a short while. And secondly, the outcome that we are sending back to the community. So resources are very important in making decisions. So that is why I'm saying it's sort of like a certain posture that we find ourselves having to portray, because in private, it's not very often that those kinds of decisions are made because of the availability of the resource, and also who's going to pay for the duration of the time that patient is on that support therapy. In government, it is the taxpayers. In private, it's going to be the medical aid funds. So those
or your cash.
Or your cash, yes, if you've raised enough.
Yeah.
Others who have been exposed to being a cash-paying patient in private, they will know that if your baby is going to ICU, they'll want a deposit of 100,000. So that's sort of the amount that's going to be used by the patient on that support treatment for maybe a period of about 3 to 5 days. 100,000 in 5 days. So those are the decisions that we make.
Wow. Okay, there's another question here. Are older women who fall pregnant more likely to have a miscarriage than younger women?
Yes and no.
Okay.
Yes, in that if the miscarriage is a result of a genetic makeup, women are born with a fixed number of eggs which get fertilized at the different stages of growth of that woman. So if now at my age, assuming that I'm 46 years old and I get pregnant, so my eggs are as old as I will be. So chances of a 46-year-old egg having been exposed to summers, winters, autumns, the springs of this life, including radiation and everything, the quality of that egg is more doubted than one that is at the age of, say, 26. So in that sense, yes. Then the no part of it comes from if it is a good quality egg, that person is less likely to have a miscarriage. But if it is about now comorbidities, a 46-year-old woman is most likely to be having high blood pressure, on hypertensive treatment, diabetes, on treatment, mood stabilizers, antidepressants, and so on. So all the combination of the comorbidities and the pharmacy medication that you are taking, those are also more likely to predispose you to a possibility of a miscarriage. So it's a yes and a no.
I wish we could take more questions, but we've run out of time. All right, so this is what we're going to do. Please send in your questions. Just send them. We'll attempt them at the next edition of Ask Your Gynae. But send in your questions. We love to answer them. Like I said earlier on, if there are things that we need to chat with you privately off camera, we do so. If there are topics or the question is generic and it's something that can benefit more women, we can answer it publicly at the next Ask Your Gynae session. But thank you so much, Dr. Gamedze, for sharing and shedding light on the subject. Thank you very, 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 very much for what you do.
Thank you.
All right.
Thank you to Pastor Toyin too.
Yes.
And thank you so much to our lovely listeners and viewers. May I also emphasize the importance of questions. The questions help us to know whether you do follow what we're doing, and also to know what will be of help to you, even if it's not related to the subject that we've just dealt with. If you have any questions, we are so very much willing to answer. If we do not know the answer, we do make effort to find out from related parties, and we bring the answers back to you. Thank you so much.
All right. Well, thank you so much. That's how much we can take for tonight. God bless you. We keep praying. Like I said, if you do need prayers, you do need any kind of support, please do not hesitate to make contact via the WhatsApp number on the screen, +27 81421 0835. Please make contact, send a message, and we will get back to you. I am available, Pastor Tony is available, and Dr. Gamedze is available. If it requires three of us to make a combined call to deal with your situation, we're happy to do it. That's why we are here. We've received this ministry and this call from the Lord to assist women. So we will do what we have to do. God bless you. Enjoy the rest of the evening. Dr. Gamedze, God bless you. Thank you very much. Good night.